the MRI of the lumbar spine would have a sagittal T1 and T2 weighted images. Additionally, there will be a third STIR or STIR image. On the T1 weighted image, the CSF in the spinal canal is hypo-intense or dark. On the T2 weighted images, this is bright. And in the STR images, unlike T2, the fat is suppressed. So it does not have the normal bright signal, but rather a dark signal. And these STR images are fantastic if you want to determine or elicit early bone marrow edema changes. Correspondingly, you have axial T2 weighted images. As said before, the CSF within the spinal canal is bright on this. On an T1, it appears hypo, intense, or dark. Moving on to anatomy, this annotated image of the axial images shows normal anatomy in which you have the spinous process, the lamina, the facet joint, and you can see the ligamentum flavum. Now, the normal ligamentum flavum is supposed to be a thin T2 hypo-intense band anterior to the lamina. Anteriorly, you have the disc, and in the lumbar spine, you have lateral recesses from where the nerves exit. So you have the exiting nerve root, and you have the traversing or descending nerve roots. So if this is a level between L4 and L5, the exiting nerve root will be L4 and the descending or traversing nerve root will be L5. Now this is important because if this nerve is compressed, it will cause symptoms associated with L4, whereas if this nerve is compressed, it will cause symptoms related to L5. In the lumbar spine, so we talked about the lateral recesses, which are best assessed on the axial images, as well as the spinal canal stenosis, which is also best assessed on the axial images. However, the neural foramina are best assessed on the sagittal images, where you have a normal keyhole appearance. There is fat around the nerve root. The degree to which this fat gets obliterated is a suggestion of the degree of stenosis of the neural foramina. And when the normal circular shape of the nerve starts getting distorted, we know that this will be associated with nerve compression. Unlike the lumbar spine, the cervical spine does not have lateral recesses. You directly have the neural foramina. So if there is any nerve compression which occurs along the paracentral locations, it is that which is happening at the level of the neural foramina. So just to bear in mind, the cervical and thoracic spine do not have lateral recesses. They directly have neural foramina. And in the case of the cervical spine, this is best assessed on the axial images, unlike the lumbar spine, where it was best assessed on the sagittal images. We will discuss cases where this will become more obvious. Now, nerve compression can happen at 4 levels, most commonly at the level of disc, going inferiorly and laterally. This could happen at the level of the lateral recess, the foramen, or the extraforaminal level. Just to get a hang of normal disc morphology, and after that we'll discuss herniation. So doing our normal counting, the last normally formed intervertebral disc space is at 5-S1, so L5, 4, 3. So the disc space at L3-L4 is normally convex forwards. At L5-S1, it has a flattened appearance, and at L5-S1, it is convex posteriorly. This is the normal appearance of the ligamentum flavum, which is thin, and this is the normal appearance of the facet joint, which is very smooth, regular margins with a normal articular space. This is just an illustrated diagram which shows the surrounding structures. Anything which involves the surrounding structures can result in narrowing of the spinal canal, the lateral recesses, or the foramina. And the first thing we're going to talk about is the disc. So the disc has a normal hydrated central nucleus pulposus surrounded by the annulus fibrosus on the images. the normal central hydrated nucleus pulposus surrounded by the annulus fibrosus. So when the disc begins to herniate, it fissures across the annulus fibrosus, which is seen as a T2 hyperintense signal. Now, these disc changes could be diffuse. So you have a diffuse overflowing disc, which is a diffuse bulge. It could be asymmetric or towards one side. You can have focal disc herniations as well. Technically speaking, if the base is broader than the summit, this is known as a protrusion. If the base is narrower than the summit, this is known as an extrusion. These discs can be associated with migration, so it can migrate cranially or caudally. Any disc that begins to migrate by default is termed as an extrusion. This extruded disc can lose continuity with the parent disc, and at this point it will be labeled as sequestration. Based on its location, these focal disc herniations can be central, they can be paracentral or subarticular, they can be foraminal or extraforaminal. Disc osteophyte complexes, these are more often at the cervical level and less so at the level of the lumbar spine. So giving an example, this is a T2 sagittal image through the cervical spine. We can see a disc osteophyte complex at C3-C4 and C5-C6. We can see that there is a degree of canal narrowing associated at both levels. It is more severe at the level of C5-C6 because you can see that it is buckling the adjacent cord, causing its compression, and there's some abnormal thinning of the cord as well, and there's some abnormal T2 hyperintense signal, which is suggesting that this is slightly long standing and resulting in myelomalacia. The corresponding axial images will show the degree of narrowing of the spinal canal and bilateral exit foramina. To highlight this better, I'll attach a normal image. So this is a normal image and this is the abnormal level. You can see that the neural foramina here are quite capacious and patent. Here you can see that the disc osteophyte complex is almost obliterating the left neural foramen and is causing severe narrowing of the right neural foramen. The central canal, which normally has a circular shape, you can see here that it is deformed with severe narrowing of the spinal canal. Moving on to disc protrusions. So we can see the T2 sagittal image. There is a focal disc protrusion and it is uplifting the posterior longitudinal ligament. Interestingly, you have modic changes at the disc. These changes are hyperintense on T1 and hyperintense on T2, being suppressed on STIR images, and therefore we know that these are fatty changes. So we have modic 1, 2, and 3 disc end plate changes, and these are based on the degree of chronicity. So an acute modic change is usually edema or fluid, so it is hypointense on T1 and hyperintense on T2. As it becomes more chronic, fatty changes happen. So these are hyperintense on T2 and hyperintense on T1. Interestingly, if you made note of the annulus fissure over here, when they become chronic, sclerosis happens. Sclerosis is calcium, and therefore it is hypointense on both T1 and T2. Moving on. Interestingly, you should be able to make out this is a female patient, so you can see the uterus. Going on, there is a disc protrusion over here, and you can see that the exiting nerve appears normal on the right. On the left, you can not appreciate it separately from the margins of the disc. So going on to the sagittal scans, you can see that this disc is abutting the lower end of the nerve, which is therefore probably splayed, but you wouldn't call it obvious compression because its morphology is generally circular and maintained. Moving on to another case, you can see there's another disc protrusion, likely with a disc osteophyte complex. You can see the end plate pointing posteriorly. You can see that the right exiting nerve root is fine. The left exiting nerve root appears to be impinged on by the disc. So the left exiting nerve root at L5-S1, so this is L5 nerve root, has been impinged. What you can see is that the disc osteophyte complex is causing compression of the traversing or descending S1 nerve root. So the right S1 nerve root appears normal. The left S1 nerve root is being compressed along the lateral recess. Disc extrusion, this is a case of disc extrusion at L4-L5, where you can see that the disc has migrated caudally. It appears to be pinching off and might eventually get sequestered. So going on into your axial images, you can see that the right and left exiting nerve roots appear normal. Coming below, you can see your descending or traversing L5 nerve roots. They both appear normal, but as you go more caudally, you can see that the extruded disc is now impinging on the descending nerve root. So as we talked before, that at L4-L5, the exiting nerve root will be L4, that appeared normal, but the descending or traversing nerve root would be L5, and that here is being compressed. Now, there can be other causes of spinal canal, lateral recess, or foraminal narrowing, which could be due to any one of the adjacent structures. This could include hypertrophic degenerative changes of the facet joint, which could be associated with synovial cyst. It could be due to hypertrophy of the ligamentum flavum. It can also be due to abnormal epidural fat, and we'll see all of these one by one. As I've shown you before, the normal facet joint here, there are hypertrophic changes, the joint space is irregular, there's a lot of sclerosis. So there's facet arthrosis happening here. This is associated with hypertrophy of the ligamentum flavum. As I showed you posterior, this should be very thin and hardly perceptible, but here it is obviously thickened and hypertrophied. Going on at another level, you can see it even more thickened. So there is a degree of hypertrophy of the ligamentum flavum, and a combination of this facet degenerative change and hypertrophy of the ligamentum flavum is causing compression of the exiting nerve root. On CT scan, this is a sagittal image. You can see that the facet joint spaces should be smooth, should be quite symmetrical in appearance, and the cortical margins should be well maintained. When degenerative changes or facet arthropathy starts, there is loss of joint space, there is sclerosis, and there is osteophytosis, as seen on this sagittal image. This is how it would appear on the coronal image and an axial image, which shows the similar changes. There is loss of the joint space, sclerosis, and osteophytosis. These facet joint hypertrophy or arthrosis can be accompanied by synovial cyst. The cyst might be directed posteriorly, where you not have nerve compression effects, but these can extend around the epidural region. So here along the lateral recess, it can cause compression of the exiting nerve roots. Sometimes these synovial cysts can migrate into the neural foramina, and as you can see here, the cyst is gone into the exiting neural foramen, and you can't see the nerve separate to it moving around. You can now see that the nerve is being compressed and distorted around this synovial cyst. Moving on, you could have epidural lipomatosis. This is a normal T1 sagittal scan in which you can see scant fat in epidural lipomatosis. This is best seen on T1 because the fat is hyperintense and stands out. So there's a copious amount of it which is deforming the spinal canal. You can see this on the axial images. This is a normal scan where there's preserved circular appearance. When this is epidural lipomatosis all around the canal, you can see it is deformed into a Y-shaped. Foraminal stenosis can happen due to spondylolysis, which is a fracture through the pars interarticularis resulting in listhesis. So you can see that this vertebral body has translated anteriorly, and what has resulted is the normal keyhole appearance is lost, and there's deformity of the exiting nerve, which is compressed due to this listhesis and anterolisthesis resulting from fracture of the pars interarticularis. You could have extraforaminal compression as well, where a laterally directed disc from the posterolateral margin can impinge on the exiting nerve root. Moving on to certain other cases that you usually encounter are METs. METs are usually hypo-intense on T1, and as they increase or diffusely inform the vertebral body, there can be a loss of height, there can be retropulsion of the vertebral body itself due to fracturing, or as in this case, there's an associated soft tissue component which is causing associated narrowing of the spinal canal. But the first thing you see a lesion in the spine, आपने सबसे पहले घबराना नहीं. This could be a hemangioma, which is the most common lesion that you see in the spine, and this is usually hyper intense on T1 and hyper intense on T2. You can see a similar hemangioma, which is hyper intense on T2 and T1 over here. You could have discitis and end plate osteomyelitis. So there'll be a lot of inflammation and edema signal. Therefore, the vertebral bodies here are infiltrated by inflammation or low signal of the edema, hypo intense on T1, hyper intense on T2, and this will be most prolific on the STIR images. There'll be associated end plate osteomyelitis as things progress, which will become irregular. There'll be fluid signal along the disc space, which will appear hyper intense on both T1, both on T2 and STIR images. So you could have changes related to infection, including discitis and end plate osteomyelitis. I think that's all the time I have with you guys. So thank you very much in a radiological manner to you guys for your patience. And I wish you all the best with the coming segments of the lecture. And as for my resources, I mostly use Radiopedia and radiology assessment. Thank you very much. Assalamu alaikum.
Thank you, Dr. Rian Pervez. It does clarify some essential concepts. Understanding radiological imaging is quite essential for our work, be it therapeutic or for diagnostic purposes. With that, let's learn from Dr. Zahid Wahid how we can get more out of our C-arm. And it would help us in optimizing the images and address the safety issues related to it. Dr. Zahid Wahid is a graduate of QMC Bhabalpur in 1991. He's a consultant anesthetist in pain medicine, Colchester Hospital, UK. Dr. Zahid Wahid will be giving a talk titled How to Get the Best Out of the C-arm.
Assalamu alaikum, ladies and gentlemen. I am Dr. Zahid Wahid. I am a consultant in pain medicine at East Suffolk and North Essex University Foundation Trust in UK. It is a rather long name, but it is what it is. And I am going to briefly talk to you how to get the best out of your C-arm. It's not a very meaty topic, but I will try to give you the things that I feel are useful. So the first thing is, why should we use C-arm? Because if you think about it, the use of C-arm does restrict where you can do your procedures, and obviously it also restricts the availability of that space to others. There are some procedures which cannot be done without guidance. And I'll talk a little bit more about this. It also increases the accuracy. So although there are some procedures which can be done without C-arm, but it will increase the accuracy. And it will also reduce the time that you use to take the procedure. And your results are more predictable. Now, I have seen some colleagues who claim to have done the facet joint injections in the clinic without any guidance. And I can bet my month's salary on this, that they were nowhere near facet joints. So they cannot be certain that they were near facet joints. Similarly, in the good old days, the caudal epidurals in the chronic pain, they used to be done without C-arm guidance. And there are studies about this, that more than 50% of the caudal epidurals that are done without guidance are not, the needle is actually not in the space where you want it to be. So if you were to say that the facet joint injection or the chordal epidural has not worked, but you don't even know whether your needle was on the target or not, then you can't really say whether the procedure has worked or not. I am also going to briefly talk about how to improve image quality. The first thing is starting position, and I will see if I can sort of explain it. So you got to be square on, i.e. if the patient is lying this way, your C-arm has to be perpendicular in that way. There should be no obliques, no tangents, no tilts on the C-arm. You obviously also has to know what position do you want to be the C-arm in for that particular intervention. Like, you might want a lateral position for doing a chordal epidural, although I would usually start with an AP view to sort of just to get an idea about the midline, because the midline on the skin may not be the midline of the sacral area. Then the other thing that you can do to improve the image quality is scan only the area that you are interested in. And you can do that by doing collimation, and the machines nowadays, they are clever. They can do circular collimation or linear collimation. So linear collimation is where the image is reduced in linear fashion. And these lines could be adjusted to go in any direction. And the circular collimation is where the circle is the size of the circle is reduced. It does two things. One, it reduces the dose that is coming out of the machine, and it also improves the image quality. So if I was to give you an example, if you are screening the neck area, but you have got a wider area and the shoulders are also coming into the view, it is just going to white out the neck completely, because the machine is going to adjust its dose according to what it sees in the image, and there will be a lot of shoulder in that. So the dose of the radiation is going to be increased, which is going to cause a whiteout of the neck area. So not only that you can deteriorate the image quality, but also increase the exposure to radiation. You can also increase the duration of exposure, especially in people who have a very high BMI, because imagine that the radiation is coming from one end and it is being captured at the other end, and there is obviously table in between and your patient. The scatter of radiation from the table is actually not that much. The maximum scatter comes from the patient, and the bigger is your patient, the more is going to be that scatter. So the your receiver, which is receiving the radiation, is not going to actually receive much of the dose. So you might want to take a longer shot, which will improve the image quality, but obviously that will increase the radiation dose as well. You can also use digital subtraction, especially if you're worried about intravascular injections. So you give a contrast and you do digital subtraction angiography, and you will know whether the contrast is within a vessel or not. And you should also have the axillary tube closer to the patient. That will reduce the scatter, improve the image quality, perhaps a little increase in the dose as well. Then protection from radiation exposure, I think this is absolutely vital. If you are going to be doing this thing for a living, for the rest of your professional life, you might as well pay attention to this, because you don't want to be exposing yourself to radiation. Although you could argue that patients don't have any protection, or mostly don't have any protection, but they are not being exposed to this day in and day out, which you would be. Lead gum, I have written at least 0.5 mm lead equivalents, but I know that there are lesser ones, 0.35 are also being used. But I think if you're going to have a stronger exposure, which we usually don't do in the pain clinics, but we do that in like endovascular surgeries, then I think at least 0.5 mm lead equivalents is better. You should also consider a thyroid protector. As I was saying, that there's a lot of scatter that happens from the patient, and obviously thyroid is a very rapidly dividing cells, and the more rapidly dividing cells are there, the more effect of the radiation is there. So you should certainly consider that. Radiation gloves, as you can see in the picture, one of the trusts that I work in, we have got these radiation protection gloves. Now they reduce the dose of radiation significantly. Although one of the trusts where I work, they don't have these radiation gloves. Then radiation goggles, again, another hospital, a private hospital where I work, they would provide radiation goggles, but majority don't have them. If you can have them, it is brilliant. They're not easy to wear though. They are fairly heavy. Now, I am also going to talk a little bit about the direction of the beam and the scatter. Generally speaking, what you want to do is you want to keep the machine. Let me see if I can make a point. So you want to keep the X-ray tube on the underside of the table. Because then what happens is, as I was saying, the scatter of the beam happens mostly from the patient. The beam is coming up, and from the patient, it will scatter like that, which means it's only your lower part which will receive radiation, not your upper part, which obviously is more vital. And as I said, use single exposure pictures or shots as opposed to live screening or videos. Now, sometimes I will do live screening, but that is not my preferred method. I will generally use just brief shots as well. Now, there are radiation dosimeters, and some trusts regularly use them. You must have seen your radiographers wearing these in Pakistan. I have certainly seen that in military hospitals in Pakistan, and the people tell me that they hardly ever become positive. But now the modern dosimeters are quite clever, and they can be connected to a computer where the amount of radiation that you're exposed to can be calculated. And if you need a break from your professional duties, that can be done as well. So generally speaking, you want to keep the X-ray tube lower and your image intensifier or the image capture system at the top. Although I think because since this is slightly more bigger, so it makes the access slightly difficult, especially if you got a big patient. Now, there is obviously a third element to this. There are three main elements, really. But the first element, especially if you are the operator, if you are the person who is doing the procedure, is quite impractical. That is distance. But the distance actually reduces the radiation quite significantly. For everybody else, it is quite important. So all your theater staff, you will see a lot of the radiographers will have these buttons on a long flexible lead. So they will actually stay away from the machine when they are doing the exposure. Shielding, as I have said, it is must. If you're going to be doing this thing regularly for the rest of your professional life, you must shield yourself and then reduce the exposure time as much as you can. It will help you reduce your exposure, your patient, and your staff. I'm just going to briefly say a few things about imaging the neck. Now, I know one of my colleagues is going to give a talk on interventions for the neck. So I'm just going to keep it brief. Imaging the neck is a little bit tricky because you have to align both sides. So imagine if you are looking at the facet joints, and let's say you're looking at either the facet joints or the exit foramini for the nerve root. So there are two foramini on both sides. So they have to be aligned in vertical direction. They have to be aligned in horizontal direction. They shouldn't be sort of in any way. So if they are perfectly aligned, only then you would know that if your needle is in the exit foramini, that it is in the exit foramini. If they're not aligned and your needle you think is in the exit foramini, you actually might be looking at the exit foramini from the other side. The other option with that is that you go oblique, which means that actually your foramini are not, both the foramini are not in the line of the exposure. Now, when we do these procedures, how much radiation do we give to our patients? And so this is primarily for the patients. Briefly, it is not a lot of radiation that we do, certainly for the procedures that we do and the way we sort of plan our radiation exposure for the patient. Now, the table on the right side, it shows you the risk of the amount of radiation that you get from a given procedure and how much is that equivalent to your natural background radiation. The natural background radiation that all of us get when we are, for each day of our life. So if you look at the chest radiograph, it gives you the radiation that is equivalent to your background natural radiation of worth 3 days. And even if you look at, let's say, an IVU, which is a lot of radiation that you do for this, it will give you about 14 months equivalent of background natural radiation. The third column in the table tells you that how big is the risk of fatal cancer from that exposure. You got to keep that in mind, that this is the risk of fatal cancer, not the risk of cancer. But for a chest radiograph, it is about 1 in a million. You have to keep in mind that the background risk for the lifetime incidence of cancer in the Western world is 1 in 3. About a third of the people will have a cancer during their lifetime. So overall, the risk that this exposure poses is not that big. Right, what about pregnancy? The simple answer is avoid if you can. And I'm not just talking about the radiation exposure, I am talking about also your intervention. In pregnancy, there is nothing that is proven to be safe. The reason is that the amount of or the quality of proof that the medical science would want is randomized controlled trials. And obviously, we won't be able to do randomized controlled trials in pregnant women. So there is no proven safety for anything. So avoid any injections that you can, avoid any exposure that you can. Now, there may be situations where the problem is causing a lot more misery than the solution might do. And then you might want to consider doing a procedure for which you might need extra guidance. So if that becomes a must, then I think you should avoid first trimester. And because first trimester is where all your organs are being formed, and that poses the highest risk. Now, normally there are procedures that you would do normally with x-rays, like all the epidurals that I do, I would do them with x-rays. But if I was doing it in a pregnant woman for chronic pain reasons, not the obstetric epidurals that you do for pain relief during labor. If I was doing a pain epidural, I would probably use it without x-rays. It is for two reasons. One is that she might have a lot of difficulty lying on her tummy for this. And the second is, you can do that without x-rays, although you could argue that you're not going to be as precise as you want to be, but nonetheless, you can avoid exposure. The risk for this is actually extremely small. So I had a patient who came in for a procedure, pregnancy test negative. We did her procedure, facet joint injections, and later on when she did not have her period, she did her pregnancy test and she was positive, which meant that at the time of the injections, she was in very early part of her pregnancy. So there was a lot of obviously commotion about this and she was quite anxious. And the chart that I have showed you a couple of slides ago, well, one slide ago, this is a chart that I gave her, and I said the risk that this poses is actually very small. She eventually had a normal baby without any problems. But obviously at that time, she was quite anxious. If you think about other things that we do during pregnancy, so let's say if a pregnant woman has come in with some sort of symptoms which makes you think that she might have a pulmonary embolism, she's going to have a chest CTPA. That CTPA is probably going to give her about 100 times more radiation than you would give her through any injection that you feel is needed. So the CTPA would also be something that would be needed if you are suspecting PE. But that gives you an idea about the dose of radiation. So the policy in our hospital is that if you suspect PE in a pregnant woman, the CTPA should be done irrespective of the risk to the fetus, because obviously risk to the mother is much higher if there is an undiagnosed pulmonary embolism. Okay, then I'm going to give you some other tips. Keep the monitor in easy view. If your monitor is like that and you're sort of doing the procedure here and you're looking at all the other side all the time, it's not going to be easy for you in the long term. When I see my colleagues who are laparoscopic surgeons, they usually have 100 monitors in the room, not 100, but at easily 5-6 monitors. Some of our urology colleagues, they even have a monitor for the patient when they're doing the TUR, BT and these things, so that whatever their position is, they can find a monitor that is placed there for easy viewing. Unfortunately, seance don't have multiple monitors. Majority of the modern seance will have 2 monitors, but they will be anchored to the same base. So make sure that it is in your easy view. I also save all pictures for as part of patient records. Not all pictures. So if I'm doing, let's say, facet joint denervation, then I would make sure that the final picture before I create a lesion or do the burn, I have saved that picture. So that, in addition to my sensory and motor thresholds, also tells me that the procedure should be effective and it should be safe. And if you are doing the procedures in a female of childbearing age, then you should consider pregnancy test before exposure. So in our trust, this is mandatory. But of course, in Pakistan, you've got to keep our religious and cultural values in mind. So you can't really ask an unmarried woman to have a pregnancy test, which you would do in UK. So I'm thinking just consider pregnancy tests if they are childbearing age and if they're married. I don't know why I put this slide up there. 3D imaging, yes, the seance can do 3D imaging. This is a lot of radiation. There's then computer reconstruction for doing 3D imaging. I cannot see any use of this in the chronic pain settings. Then I am going to talk a little bit about alternate ways of guidance. Ultrasound, it has many advantages. Although you cannot use it for everything, but if you can do a procedure under ultrasound, it is not just the radiation, but also ultrasounds are very portable. They're really small machines, so which means that you will be able to do many procedures without needing to come to theater, without needing a theater. Then there are, if you have not heard this, they certainly happen, CT guided injections. I have a slightly cynical view, and I'll tell you why. But there's no evidence, not just hardly any evidence. There is no evidence that they provide any extra benefit over the C-arm. Whether you want to do something more precisely, I certainly know that there are some radiologists who will do CT guided celiac plexus blocks, and they will not do it with the C-arm guidance. So perhaps because that's not their main area of training and expertise, so perhaps that's why they need them. So there will be some areas where you might need them for more precision, but also depending on user experience and training. But I have even seen somebody who was in Australia, I think, had a CT guided nerve root injection. And my view is that these things tend to happen in countries where the payment for the procedure is insurance-based, because insurance-based means that if you do it under CT guidance, you get paid a lot more than if you do it under C-arm guidance. But that's my cynical view about this. Right. Any questions, please feel free to ask me. Thank you.
Thank you, Dr. Zahid Waheed. I know that many of us would like to ask questions at the moment, but just let's hold it a little bit longer till our last segment, in which the panelists and the speakers will be around to answer all the questions that you may have. Our next segment is image-guided pain procedures in action. So these were recorded in pain procedure room and has typical voice background that you would find in any theater. So let's start with our three pain procedures. First would be the caudal neuroplasty, transforaminal approach to epidural injection, followed by the celiac plexus neurolysis.
Welcome to the Intervention Pain Management. Today we are going to do the caudal neuroplasty procedure for our patient. For this purposes, we need standard monitoring. Standard secured IV access with running IV fluid. Emergency medicine for backup, along with the medication in case the patient requires sedation. For this procedure, we require patient in prone position. It is an uncomfortable position, however, if the patient may require sedation for a more cooperation in procedure position. We need a pillow which is placed under the abdomen, and the purpose of having this pillow is to have full flexion of the lumbar spine. That helps in case the caudal epidural is not successful, then we can go on for an alternative procedure of interlaminar epidural. So this is our procedure trolley. In this one, as you can see, there are medications which are syringe coded because we do not have sterile labels. So the one that has got this orange needle on it is a 2% lidocaine, which is in a 10 cc syringe, to make it differentiated from the syringe which is lying next to it in a 5 cc syringe. The contrast ultraviolet is taken. The other 10 cc syringe has got triamcinolone 80 milligrams and normal saline. This 10 cc syringe is differentiated from the local because it is more milky or turbid in color. The needle which is being used is a 16-gauge 2 weeks needle for caudal epidural. As the procedurist is going to put a catheter down, therefore the 2 weeks needle is ideal for this reason. On the one side of the trolley, we have got 2% chlorhexidine solution in a telepot with a sponge holder. It is kept separated from the rest of the trolley, and it is carefully handled because the 2% chlorhexidine contamination can lead to neurological damage if it comes in contact with it. So The needle which is going to be used to this needle is kept quite separated from the chlorhexidine. Skin preparation. The exfoliant is extremely important in this one to ensure complete asepsis of the procedure. From the mid-thigh to the upper part of the back, the chlorhexidine solution is taken in the belly pot and scrubbed onto the relevant area. What's extremely important is that the liquid does not spill into the perineal region because it will be very irritating for the patient and make them uncomfortable. Patient is draped in sterile drapes covering the entire length of the patient except for the area in which the intervention is to be done. To emphasize the point about the chlorhexidine, as you can see after the patient is prepped with the skin prep, the chlorhexidine is not returned to the procedural trolley. This is shallow angle technique for doing caudal neuroplasty. The C-arm view is lateral. This is the first shot of sacrum in the lateral view. As you can see that it has to be an optimal view. It is important to have an optimal view of the sacrum at this time because if there is too much of air on the upper end, then it would reach the suboptimal view or suboptimal view of the sacrum. The level of the C-arm has to be in line with the patient's sacrum so that not much air is coming in that would be the suboptimal view of the image. In the sacrum, you can see this is the ventral plate of the sacrum and this is the dorsal plate of the sacrum which is extending over there. So this is sacral cavus. The entry point that you will see in the middle coming in from would be the this angle entering into the sacral cavus. Now to ascertain the puncture site of the needle, the surface marking is done with the radiology. So with the sponge holder, one can visualize where the puncture site would be. And with the sterile marker, a mark is made where the sponge holder was as an entry site. On that mark, which was made with the sterile marker, a small scratch is made, local anesthetic going in. This is the 2% lidocaine which is going in. The local anesthetic after infiltration is given 2 times for it to work. With this shallow angle technique, the Tuhi's needle is inserted at a 45-degree angle to the point that it has now hit the dorsal surface of the sacrum. So this is hitting the bone now. Once it has hit the bone, we can take another shot on the radiology. So with that shallow angle technique, the needle has now entered into the sacral cavus and was initially hitting the dorsal part of the sacrum but withdrawn a little bit as is shown in this radiological image. Now the angle of the needle is reduced in order for it to enter into the sacrum through the sacral cavus and further in. The needle has been advanced by reducing the angle and it is into the sacral caudal space now. To ensure that the needle is in the right space, a contrast is injected up to a volume of 1 ml. In this radiological image, the contrast is coming out and spreading into the caudal space satisfactorily. The AP image is taken as a safety view to ensure that it is below the S3 level or the inferior part of the SI joint. In this AP view, The tip of the epidural needle is below the inferior part of the SI joint and below the level of the trochlear foramina, which is the foundation. The epidural catheter is being threaded in through the Trolley's needle. It's important to warn the patient regarding the threading of the catheter, as they might feel a little bit of a sharp pain. Through this catheter, contrast is again being injected up to a volume of 1 ml. This is to ensure the position of the epidural catheter relevant to the pathology. In the AP view, the contrast is visualized. You can see the Christmas tree appearance of the contrast in this image, and there is more on the left side, which is the side of the pathology. That determines that the catheter is in the right place relevant to the pathology. Okay. The 80 milligram triamcinolone in normal saline is again shaken so that the particles are equally distributed and they are not lying lower down in the thread. After the satisfactory confirmation of the contrast, triamcinolone 80 milligrams in normal saline after negative aspiration is being injected slowly. After every couple of minutes, it is aspirated to ensure that there is no blood or CSF coming back. At this time, it is important also to warn the patient about any pain related to the pressure, and it could mean that you need to give it more slowly. After having injected the main drug, the catheter is flushed with normal saline and is pulled out. To ensure that the blue tip of the epidural catheter is intact, so that there is no shearing off of the catheter. Local anesthetic injected through the trap of the epidural needle while it is being pulled out. Compress the area with a sterile swab so that there is no bleeding, and then sterile dressing is done on that area. The procedure is finished, and afterwards the patient will be kept supine for 15 to 20 minutes in the post-operative recovery unit, where the patient is monitored for saturations, heart rate, and blood pressure. Before the patient is discharged, he is again seen by the pain interventionist, and to ensure that there is no motor block and the legs are working well. At the end of the procedure, the shafts should be discarded by the person doing the procedure into the shaft bin. It is to ensure that it is discarded fully, and it makes it safer for the physicians and the staff working there. Yeah.
Now we have completed our first video of caudal neuroplasty. Now we will be moving on to our second procedure, which is a transforaminal approach to the epidural injection.
We'll be doing a transforaminal epidural in this session. For this procedure, we need a steroid monitoring.
ECG, pulse oximeter, and the non-invasive blood pressure. Patient should have an IV access and attached IV fluid along with it. For this procedure, the patient is positioned prone with the help of two pillows. One is placed under the abdomen. Patient skin is prepared with a 2% chlorhexidine solution, ensuring that the entire area is prepped properly twice. The entire prepped area with the 2% chlorhexidine is draped with sterile sheets.
Yes.
The sterile procedure trolley is prepared. In this one, we are using a 10 centimeter echogenic needle which has a blunt end to avoid the penetrating injury to the nerves. Along with it is a 25 gauge needle 10 cc syringe containing 2% lignocaine and a 5 cc syringe containing contrast. For the transforaminal epidural, we use 40 milligram triamcinolone with in 5 cc syringe.
Sure.
The timeout is done before the procedure.
Introduction of team, please. The patient name and MR number. Surgical procedure.
It's left-sided transforaminal L5 epidural under fluoroscopy.
Is the surgical side marked?
It's marked with the arrow there. The
Surgical
left
position.
side position is prone.
How much blood loss?
Minimal.
Any special investigation implant required?
Just fluoroscopy.
Any critical step you want the team to know about?
Nothing specifically. It's under local anesthetic.
Anesthesia side patient specific concern.
So it's not under general anesthetic or sedation. Just the local anesthetic here.
AIC scope.
Yes.
Level to support required.
Standard monitoring as per AGBI.
Stubborn sterility of instruments been confirmed.
Yes.
Any equipment late issue?
No.
Antibiotic of the axis.
Not required for this procedure.
As a surgical site infection fundamental taken, patient warming.
Yes, surgical site infection undertaken
Hair
and
removal.
patient is warm.
Hair removal.
Not required for this procedure.
Glycemia control.
Patient is not diabetic. It's
And
online available if required.
AP view of C-arm is taken to determine the level of lumbar spine. The lumbar spine AP view is taken to demonstrate the L5 lumbar vertebra. Along with it, the left side of the patient is the left side of the screen. On this one, we can see the Scotty dog, the pedicle, the superior articular process, and the transverse process. This is the S1 upper and superior end. The superior end plate of the interested vertebra is leveled off so that there is only one line which is seen. This is done by the craniocaudal angulation of the C-arm. Now the oblique view of the C-arm is taken. The C-arm is oblique towards the area of interest. The Scotty dog is becoming more visible on the oblique view. The Scotty dog is more visible now with the drawing, in which this is the eye of the Scotty dog, with the ear of Scotty dog, which is the superior articular process, the transverse process, and the front leg of the Scotty dog. The insertion point of for infiltrating the local anesthetic is the chin of the Scotty dog, which is marked under the fluoroscopy. This is going to be the insertion point of infiltrating the local anesthetic under the chin of the Scotty dog. The local anesthetic is being infiltrated on the mark which was made on the skin. 2% local anesthetic infiltrated after warning the patient. The local anesthetic is infiltrated and ensuring that there is no blood coming out. The more local anesthetic is infiltrated in the direction of where the needle would be going. 10 centimeter long echogenic needle with the blunt tip is used.
Short. Sure.
The needle is passing through the same insertion point which was marked earlier.
Sure.
The needle advanced in the tunnel view in line with the beam of X-ray, ensuring that the tunnel view is achieved.
Sure, please.
Once the direction of the needle is ascertained in the tunnel view and the usual depth of about 5 centimeters is achieved given the patient's body habitus, the C-arm is then taken into the lateral position. The needle is in the tunnel vision right now under the chin of the Scotty dog. Now we are going to move the X-ray into the lateral position. So in the lateral view, the patient is positioned such that there is not much air coming in the view that would compromise its quality. So in the lateral view, we have the L5 vertebra confirmed along with the top of the sacrum. This needs to be confirmed again because sometimes there is lateralization or lateralization of the lumbar vertebra. And in this one, the needle which is coming is the tip of the needle is far out at the moment. The intervertebral foramen is over here, which is outlined like a keyhole. Along with that, we have got some facet joints and a facet joint over there. So the needle is quite far out at the moment.
Sure.
The needle is advanced, taking the shots in between. The needle tip is in the intervertebral foramen now. So this is the top part of the intervertebral foramen, which is safer from any artery or nerve which could be over there. So this is the safer quadrant of the intervertebral foramen for the 1/3 of the intervertebral foramen. After confirming on the lateral view that the needle has reached into the intervertebral foramen, we are going to take a safety view, a true AP view, to ensure that the needle is not too far medial that may result into the puncture of dural sheath. So in this safety view of AP, we have got the pedicle roundabouts over here. This needle to tip position should be bisecting the pedicle in two halves, and the tip of the needle is outer to the 6 o'clock position. So it should not go further than the 6 o'clock position, otherwise it would be too far medial and leading to the dural sheath puncture. The extension needle is flushed with the contrast and is attached to the needle. The reason of using an extension needle is to ensure that the needle position is not changed and is absolutely still in the place. 1 cc contrast is given to ensure that the spread of the drug would be optimal and to rule out the spread into CSF and blood. The spread of the contrast shows over here along the nerve root and also medially, which is around the pedicle, going a little bit more in the epidural space. This is the optimum position of the contrast spread. It is to rule out any spread into the blood. After giving the contrast and taking an AP view, we are going to take a second safety view in lateral position. In the lateral view, the tip of the needle is in the intervertebral foramen, and after giving the contrast, one can see the spread of the contrast going into the anterior epidural space up to the level of L4. The 40 milligram triamcinolone in up to a volume of 3 ml diluted with normal saline is shaken to ensure that the particulates are not settling down, and then is given through the extension line. Aspirating to ensure that there is no blood coming back. As it might be a tight space, therefore it is injected slowly for the patient's comfort. With normal saline, the extension line is flushed to ensure that the maximum drug is being deposited in the area of interest. So now we have finished the transforaminal epidural injection, and the insertion site is covered with a sterile dressing. For further monitoring and to give the discharge plate.
Now that was transforaminal approach to epidural injection. Our next pain procedure video is about celiac plexus neurolysis.
Today we are going to do a celiac plexus block retrocrural approach with 2 needles. For this we would have a patient monitoring with ECG, pulse oximeter and blood pressure, running IV drip which is required to counteract the post-procedure complication of hypotension. For this procedure the patient has to be positioned prone to increase the flexion of thoracolumbar spine. The procedure is done in sterile condition with 2% chlorhexidine skin preparation done twice, along with the sterile drapes along the site of the procedure. The sterile trolley for this procedure is prepared. Since we do not have For this procedure, the sterile trolley is prepared with all the drugs being drawn up. As you can see, the two 10 cc syringes with the needles are having alcohol, absolute alcohol in it. The reason for keeping the needles on the syringes is to ensure there is minimal evaporation of alcohol. Then there are 18 gauge 15 centimeter Shiva needles for the carrying out the procedure. 25 gauge needle 10 cc syringe has got 2% lignocaine. Along with that is a 5 cc syringe of contrast. The 2 syringes of 10 cc without any needle on it is containing 0.25% bupivacaine.
Everybody covered?
AP view of the thoracolumbar spine is taken from the C-arm. In the AP view, L1 vertebra is identified. The vertebra having the spun stick image is L1 vertebra. The vertebra above it having the ribs on the sides is T12 vertebra. So the L1 vertebra is identified and marked on the patient's skin. With a sterile marker, spinous process of L1 vertebra is marked on the patient's skin and is written as L1 for later reminder. Start. The target L1 vertebra has superior enclave which is squared off along with the inferior enclave which is also squared. So you can only see one single black line rather than a hollow of the line which usually comes like this. So it needs to be squared off before starting the procedure. The spinous process of the L1 vertebra is almost in the middle of the vertebra, along with the pedicles which are onto the sides. And this is the transverse process of the vertebra. Now we're going to mark the skin by looking at the X-ray image and identifying the lower border of the 12th rib and about 7 centimeters lateral from the spinous process. 2% lignocaine is infiltrated in the marked or identified puncture site. The Shiba needle is inserted through the anesthetized skin point. The bevel of the Shiba needle is kept medially.
Sure.
The needle is advanced and is kept below the transverse process of L1 vertebra, aiming to hit the lateral side of the L1 vertebra. The Shiba needle is advanced up to the lateral part of the L1 vertebra, and now one can feel that it is hitting onto the bone. Angle of the Shiba needle is changed to more acute and is passed such that it passes interior to the L1 vertebra. The needle is redirected such that it is now, instead of hitting onto the lateral part of the L1 vertebra, has now passed interior, almost interior to the L1 vertebra. This is the AP view, and therefore one can see the tip of the needle a little bit beyond the vertebra. The needle position, which was advanced in the AP view, is now confirmed with the lateral X-ray view. The needle tip position is just interior to the L1 vertebra in the lateral view. The contrast syringe is attached to the Shiba needle. By aspirating, confirming there is no CSF or blood coming, giving a volume of up to 1 ml of contrast through the needle to confirm the spread of the contrast in the lateral position. Injecting 1 ml of the contrast, you can see how adequately it is spreading along the interior border of the L1 and L2 T12 vertebra. The contrast is also checked in the AP view, and this is the spread of the contrast, which is in the paramedian. This is an acceptable position of the contrast spread. It could be ideally over here as well, which is a little bit more medially. What would be not acceptable is having a too lateral spread of the contrast. The spread of the contrast is also checked in the AP view to ensure how the spread is going. So the contrast is spreading around about over here, which is a bit paramedian. Ideally, it should be a little bit more medial. What is not acceptable is having a too lateral spread of the contrast. 0.25% bupivacaine is injected after aspiration for CSF, blood, and urine, since the kidney is on the right side as well. After waiting for a few minutes, the bupivacaine should have anesthetized and decreased the consequent pain of injecting alcohol. So 100% alcohol is being injected after again aspirating. The alcohol is quite painful, therefore one has to be careful about movement of the patient at this time. 2% xylocaine is being infiltrated along with the taking out the Shiba needle. It is to ensure that the alcohol is not in the withdrawal crack of the skin.
So now we move on to our Q&A session. We have our distinguished speakers, Dr. Rayan Parvez, Dr. Zahid Wahid, with us. Along with that, we have our respected panelists, Dr. Usman Bashir. Dr. Usman Bashir is the consultant in anaesthetist and pain medicine at Call Associates CSST, Anesthesia and Pain Medicine. Dr. Romana Shera Durrani. She is a consultant in anaesthetist and pain medicine at Shaukat Khanum Hospital. She is also CCST, Anesthesia and Pain Medicine. Dr. Romana, can you hear us? Yes.
Yes, I can hear you.
Assalamu madam.
Assalamu alaikum ji. How are you?
Good. And Dr. Atikur Rahman Ghafoor. He is consultant in anaesthetist and pain medicine at SKM, CCST, Anesthesia and Pain Medicine. Assalamu alaikum. So now we start with our Q&A sessions, and the participants are requested to type their questions in Q&A rather than the chat box. Dr. Hassan bin Khalid is our FCPS pain module rotation resident, and he will be helping us with the questions as well. Thank you, Dr. Hassan, for co-hosting. So we'll start with our first question. While we're waiting for the participants to write their questions, I have a question regarding radiation. Dr. Zahid Wahid has mentioned digital subtraction angiography. Can you please elaborate a little bit on it? What is it and how would it help us? Dr. Rayan, would you like to?
Yes, please. Sorry, आपकी आवाज थोड़ी कट रही थी. Could I take the question again, please?
It's regarding the DSA. What is DSA? A little bit like, elaborating on it. And is it like good to have, or is it essential to have for the pain procedures? How would it help us as pain physicians?
I think this would be related to somebody who's doing the intervention or digital subtraction angiography. I think ये उनसे related होगा जो fluoro कर रहे हैं, I believe. But
if you could describe a little bit, what is DSA? As in, like, what does it do?
As you can take the background image, and if you give a contrast, so you can subtract the background image from the contrast image itself, and that gives you details of where the contrast has gone. So it's just a form of subtraction in geography where you can subtract a background image from the current image acquisition.
Right. So I would imagine that it would be very helpful in ruling out the vascular injections. So if the contrast is going into any vessel, we would be able to see it with the DSA in form of live runoff, whether the contrast has gone into a vessel and disappeared off, or is it staying back? Am I correct in my impression?
Because that's the thing. What you've actually done is the background noise from your osseous structures that is subtracted from the image. So now what you have is only where the contrast is tracking and where it is extending into. So you can more easily say where this contrast is running off to, and if it's going along the path of the vascular structure, so you know that it is going into the vascular axis.
Right. And how much radiation dose does it increase in? Is it like a lot of radiation dose that goes in while the DSA is on?
No, not really, because it's just a very low dose background image which is taken and then subtracted. So there's not a significant difference between that and the normal angiogram.
Right. So that's really good, because on one hand, it's really good to have to rule out the vascular injections, and on the other hand, it's quite safe for the patient in terms of the radiation dose cumulatively that patient is having during the procedure. Is it like present in all of the C-arm fluoroscopy machines that we normally use in pain procedures, or is it like a kind of a specialized feature that only kind of a software that is installed in certain machines?
As long as the C arm is not prehistoric, it should be there on all the new scanners, at least all the ones that I've worked in, they've had it. Unless आपने कोई बहुत बाबा आदम के ज़माने का scanner लिया, तो it might not be there, but otherwise it should be.
So this is something which is quite a standard feature now in all the CR machines, and something that probably we all should be looking into if we are upgrading our equipment as well, that it is present in our new equipment. There was this mention about the CT-guided injections, neural injections. Is the CT-guided injections far more superior in terms of the safety compared to the normal C-arm injections? Is there any kind of advantage in terms of safety with CT injections?
CT is giving you more of a cross-sectional imaging, so you know exactly where your needle is going. It's not presumptive that if I'm going in this pathway, because fluoroscopy is just the difference of the guidance is similar to what you'd say between an X-ray and 3D imaging. The CT can yes, you're more aware of the surrounding structures at each step whilst the needle is progressing. So definitely in certain regards, it will give you more anatomical detail to where your needle exactly is placed and where it is going.
Can I just comment on that,
Yeah, sure.
Dr. Mas?
Yeah.
So thank you, Dr. Ayan. Just regarding the CTs, as an interventionalist, there are pros and cons if you compare the CT scan with the fluoroscopy there. So as the Dr. Zahid Wahid has mentioned in his talk about the evidence in relation to CT, superiority presumptively, as compared to the fluoroscopy, so there is no evidence there. But surely, as the Dr. Rayan said, there is axial images that you can see there. So I have done like the Celiac under CT guidance. It's far superior in relation to watching your needle tape and the relevant structures. You really see it there, like where you are actually going, as compared to what's on the fluoroscopy. But there is a really downside there. So once you're used to do it under fluoroscopy, it's a lot of space for yourself around the patient, the room available for doing anything, as compared to the CT there. So CT is kind of tunnel there, patient is moving in and out, you're going in, passing the needle millimeter by millimeter in and coming out. Or maybe you have a suite there where you can see the screen, the radiographer is helping you inside there. So at the same time, the dose itself, the radiation dose you're getting with the CT as compared to the fluoroscopy, and then comes the cost and the availability overall in your institution. Most scanners are too busy with the diagnostics there. And the rest of the time left is more kind of the interventions that can't be done under the fluoroscopy there. So it looks like the future is for the city, as the biggest centers are doing a lot of interventions in the city there. But for the timing, if you look into the scientific evidence, so I think so that's not really there yet.
I think this is like down to the training and what one is getting used to in their training. So people who are used to having probably CT-guided injections are comfortable doing that. But yes, as you mentioned, the pros and cons and the cost implications and cost effectiveness, that has to be considered as well. Pratik, if I may ask you, it's like celiac plexus neurolysis, the video that you did over here. You demonstrated a 2-needle retrocrural approach. Are there any other ways of doing the celiac plexus neurolysis?
So there are a number of ways that you can do this block there, either neurolysis or the simple block there. So the approaches that have been described in the literature are like the retrocrural that we have demonstrated in our workshop there. The other is anticrural there, and then there is a transgastric approach that you can do either the ultrasound or the fluoroscopy. And then there is endoscopic guidance, and then there is an open surgical technique like where you're doing the laparotomy and at the same go you do the celiac block there. So a number of approaches there that you can approach the celiac plexus there for the block there.
So which one do you find more effective or more relevant to your practice?
So in our institution, we do a lot of this block. We do have a good number. We published our data about 2 years ago there. So we have been doing here the retrocrural approach. So if you look, if you review the literature regarding the techniques there and the outcomes, so more or less all the techniques generally yield the same results there. Although there's a one paper that supports there, like if you're doing the retrocrural, it does kind of spreads all the way along the splanchnic nerves and giving you the better results. I know like there are a few colleagues like who supports a lot transaortic approach. That approach to make a lot of sense under fluoroscopy because you really know like you're going across the aorta and the celiac, you know, like it's just anterior to the aorta where the celiac trunk is originating there. So you really know like your anterior to aorta and your neurolytic agent or whatever the block you're doing, it's going to spread in that area and going to get the block at a target where you want. But looking into the scientific evidence, all the approaches more or less the same results there. But the main thing that matters there is the volume of the medication. And in case of the cancer patients, the timing of the intervention that when you're doing it.
I believe that, Dr. Peek, you have a study in your celiac plexus as well. So that was on celiac plexus neurolysis versus RF. So how's it, what was the idea behind it and what are the preliminary results, if you will share?
Thank you, Dr. Mas. So if you look like into the pain interventions and kind of Google or PubMed, the scientific evidence behind the pain intervention, the only intervention you will find a lot of evidence is the celiac plexus. So there are a number of trials that have been done. There are a few good that's going on. The trial we are doing in Shaukat Khanum Memorial Cancer Hospital is first of its own kind. It has not been done to my knowledge or as per the literature search there. So the rationale behind it, you know, like celiac itself, 70 to 80% patients do get relief after the injection. So it's variable depending upon the intervention and the approach, but generally that's what the figure is. So what's happening with the rest of the like 20 to 30%? Why they are not getting the relief there? So there are a number of reasons for that. One could be the technique, and the other, your neurolytic agent is not reaching to the target there where you want. So what we thought here, like the rationale behind the study, if you combine the neurolysis with the splanchnic nerve RF ablation, so the success rate of the block may go up. So in one group, we are doing the celiac plexus neurolysis only, retrocrural approach. In the other group, we are doing the celiac plexus retrocrural approach with the RF ablation of the splanchnic nerve. And we're going to see like what's the outcome there, whether combining two approaches increase the percentage regarding the pain relief wise, or it's more or less the same. So we have by now like recruited about around 40 patients, 5 or 6 patients only left as per whatever we have decided on the statistical analysis. So I'm hoping like we do have the results like in the coming 6 months.
Great. We will be looking forward to your results.
Thank you.
To see what would be good in our population. And when you see the cancer patients for celiac plexus, how do you plan them? What is the best time? Like, because in cancer hospital, Shaukat Khanum, you have like in a very early access to these patients as well during their course of disease. So when do you feel is the best time to do a celiac plexus neurolysis?
So that's a very interesting question. Like, so most of the people do ask you this question in relation to the cancer pain and the intervention. So, you know, like most of the patients coming to the pain clinics, they are generally at the advanced stage. So they are not the one like coming to the early disease. So you do get a referral, but generally at advanced stage. And these group of patients generally have a very severe pain. They're already on the medications. The medication is already in our setup, like taking the analgesic consumption of our patient already kind of touching the roof there. So timing wise, there is no consensus regarding what time we should be doing the intervention in the pain patient. So there are a couple of societies like the Dutch Society generally quoted like they do recommend early intervention. And coming back to the celiac again, like there is a study, a very interesting one, randomized controlled trial, and they have seen like if you're doing a celiac plexus block when the patients are on the step 2 of the WHO analgesic ladder, as compared to the patients who are on the step 3 of the WHO ladder. So the patients with the step 2 one do get better relief. and their analgesic requirements go down after the block. So if you ask me like a personal experience, I would suggest getting the intervention done early does make a lot of sense in cancer patient. So for example, if you know like it's a pancreatic cancer, it's involving the head gonna cause generally a lot of pain as compared to the tail of the pancreas. And you know, patients note for the surgery, it's an unresectable disease. So we all know like with the passage of the time, disease is gonna get worse and it's gonna encase all the surrounding structures there. So if you're delaying the interventions, actually what are you doing here? You're making the things difficult for your own self. So your neurolytic agents may not be getting to the target there. So that's the way I generally explain it, very simple, like you may not be getting the nerves itself blocked. And the other point, doing it early is, you know, cancer patients, their journey with unresectable disease is generally down the road. So they get a lot of malnourishment and weak over the period of time. So if you're doing an intervention on a patient that can't even like take the medication, it doesn't make sense. Like many patients, like they have a lot of pain, they need sedation. So you just have to like kind of tailor things like the time would be the best if you do it early. Then they can tolerate the procedure.
Dr. Moana, are you with us?
May I ask a
Yeah.
practical question,
Yeah,
Prateek,
sure.
relevant to the practicalities? Because sometimes, as you said, that we get them quite late. And if the local spread is quite advanced, like how do you then determine, is it your study is also looking at that when you do additional flattening nerve to cover the additional spread? Because by the time scan was done, if the patient is presented a month after, and there has been more advanced local spread, which may be outside the area of supply for celiac.
So that's one of the limitation of the study. When I discuss it with you, you guys know like the British Pain Society president Arun Bashkar, he does a lot of cancer pain there. So when I discussed this study with him, like that was the point he raised. So the extent of the disease is quite variable with these patients, but at the same time, running a randomized controlled trial intervention-wise, it's a very hard job in cancer patients. So yeah, that's a limiting factor. We generally don't see that, but once we want to analyze the data, we may be taking that factor into account, why the patient has gone to lead to the neurolysis, what was the disease extent there, what was the spread of the contrast. So yeah, that point will be there. Like at present, we are not looking into it. We'll see like once the study is completed.
Excellent. Thank you.
An open question to all the panelists now. Dr. Romana, if you can hear this one as well, please. How do you titrate the ongoing medication that the patient is on before the procedure and after the procedure? Because obviously they are, as Prateek mentioned, is on a lot of medication and opioid. So once they get an effective block, there's a risk of like, you know, overdosing on the medicine as well. So how do you titrate them? Any panelist? Dr. Romana? While the admin side looks into unmuting Dr. Romana,
yeah, I can
please,
take
yeah,
that.
sure.
Yeah. So initially, once you do an intervention there, a week or 10 days, the patient medication generally going to stay same, or maybe it's going to go up. The reason itself, the procedural pain, as I said, like their functional status is not so good, so they may feel a lot of pain, like whatever you have done, like procedure wise. So itself, the neurolytic block sometimes takes time. It's generally like to make any decision or any point about their success or the failure. It's always good, like they say, like you by 2 weeks there. So itself procedural pain related to the neurolysis, your analgesic requirement may gonna go up like for a week or 10 days. Once the neurolysis is gonna work, your analgesic requirement will go down. And generally, it's not kind of a hard issue to titrate downwards the opioids in cancer patients. And as you said, the dosiness or the overdosing in the cancer patients, they're already on opiates for the longer run there. So that's not an issue. And that's once the pain is going down, like in acute pain patients, so their analgesic may not be keeping them up. So that's not an issue here, right? At the same time, it's not only the single pain they have. Generally, they do have multiple pains. So you're addressing like the one that's severely bothering them. So keep in mind, there will be other pains, they're going to need the analgesia as well.
Yeah, that's very
And related to that point, I mean, your institute might be very good at follow-up and stuff to arrange that. But practically speaking, I have seen, like, because I work in the private setup, and a lot of patients in some other centers who have done the celiac plexus, because the patient counseling was not done properly, so they end up like presenting that, oh, the celiac plexus was done, we are still in severe pain, but just done 2 days ago. And they present. So we need at institutional basis or some national guidelines to guide other centers as well, that when you do these procedures, you need to educate the patient and the relatives properly at what to expect. Set the expectations right.
So Dr. Swan, here comes the proper training here. So if you have
Exactly.
proper training programs, your residents are not just only attending the workshops and doing these interventions. So pain is kind of not only this, this intervention is just a small part, like
Exactly.
I tell them residents. The bigger part is like facing the patients. So it's not only the interventions that's going to work for them, it's how you deal with them.
Absolutely.
So that's very important. That's where the training comes in. That's where like we all kind of working and arranging the fellowship programs where they rotate with you. They see like when to say like, no, it's, you don't need it, and when to tell them like, okay, just hold on, it's going to work for you. And that's the time it's going to take there. And you know, like Shaukat Khanum got recognition about a year ago, like for the program. At the same time, Hamid Latif Hospital in the National Hospital. And we do have other centers in the country now. And that's the whole concept there, to prepare properly trained pain specialists. So who can guide the patient in a proper professional way. So the patient expectation can be realistically met.
That's very, very important. That's what I just want to highlight. Thank you.
So, coming to the transforaminal epidural injections, what are the relative risks and benefits of different approaches? Because you do a supraneural, you do an infraneural approach. So, what's your normal practice like? Which approach do you like personally, and what are the risks and benefits of the two?
Very good question. I think Atik very nicely demonstrated in the workshop as well. The first factor which comes into play is your training. That the way you have been trained, that becomes your comfort zone, and you keep training in that aspect. And second big aspect in this is the safety. So as long as you're aware of the major risks associated with that and how to counteract them, that is the key thing. So my training was mostly in the suprarenal subpedicular approach. Hence, I've mostly stuck to that unless I'm challenged by the anatomical stuff. The key safety consideration which came with transforaminal were related to the vascular spread of the particulate steroid, particularly if you're doing from T8 to L3 level, where artery of radicularis magnus feeders come in. And that was the main catastrophizing complication which prompted all this debate into particulate versus non-particulate. And that is the main difference between the two approaches. With the subpedicular approach, there is overall, like, it reduces the risk of overall intrathecal or neural injury. But if you go too ventral, then the likelihood of vascular injury increases. And with infraneural approach, that is the main advantage that you get, that your probability of encountering a radicular artery is less likely if you're in the lower third of the foramen. However, again, it depends upon the training and your own comfort zone. As long as you're aware how to minimize that risk, even if when you're doing a subpedicular approach, that is the key thing, which trainees and the performers should be aware of.
So the two safety points that I gather from this one is that one, that what we talked about earlier, the DSA, digital subtraction angiography, that would help rule out the vascular injection, especially if you're using a particulate one. The second is the intervertebral foramen. Where do you place your needle in the intervertebral foramen? So
yes, if you're going with subpedicular approach, then tend to avoid going far too ventral, because then you increase the likelihood of getting the vascular injury. And every center then develops certain guidelines of their own to reduce according to the, like you saw in the workshop which Atik demonstrated. they say once you reach the end point, then even to reduce the slight movement of the tip of the needle, there are certain steps like Atik connected the connector so that the needle tip doesn't move. So even that slight movement, you have aspirated, but by the time you've connected the syringe, there might be a slight movement, and that slight movement might be enough. A lot of time arteries or vasculature collapsed, but you didn't get any aspirate, but it still ended up the particulate steroid going into the vessel. So these little safety tips add up quite a lot. And then there are statements, I'm sure that will bring us to the discussion of like particulate versus non-particulate, which area to do what. Like 2 to 3 years ago, I think.
Can you just add on here, like just to just with legal like we're talking about subpedicular and supraneural there, just to make it easy, like for as this one mentioned, like every center have their own approach. So the center where I was trained, they were saying always upper and outer one third. So that's very easy. Upper and outer one third. So once you're on the lateral there, you're taking lateral image, you can see forming, and mind it, it's two lateral. It's two lateral. Once you're seeing that.
If you can demonstrate on it on the spine model,
I don't know, like you can
because
see
that's
here
a very key kind of a concept that needs to come in.
So, for example, if we are doing kind of like that's L5 there, let's take the L4 there, like so you see like the nerve roots are going down there. Supranuclear area, you have a lot of room there. So
can you demonstrate again, because the video just shifted onto you now? Yeah.
So see here, for example, that's L5 there, L4, and that's L3. So just for the purpose of demonstration, I'm taking the L3 there. So I am taking lateral image there. So on the screen, you will see the foramen like there, we can see here. So your needle is coming like this from here. So what they say, keep it in upper one third and outer one third. Okay, so that's the way you're not going too ventral foreign. Hit the cecal sac here or the epidurals or the dura mater, and at the same time, if you're in the upper one third, you're not hitting the nerve root there.
Sure.
So upper and outer one third. But at the same time, if you're going too AP and your needle is too far out the pedicle, you see the pedicle and the pedicle, you know, like in the AP, it should be 6 o'clock. It's little out. Yeah, you have a little room to move it in.
Yeah, the key
just make sure that you keep on aspirating there.
And another key like tip is not to go beyond the 6 o'clock position.
Absolutely.
Far too medial to avoid intrathecal injections.
So these are quite vital. The other thing is regarding the particulate and non-particulate steroids. Why do people still give particulate steroid? Is there any kind of benefit that leads them into going into particulate steroid again, and not abandoning them considering the risk of intravascular injecting and TIAs?
I think this whole debate started a few years ago and it ended up releasing a statement from British Pain Society and Faculty of Pain Medicine, released the whole document in terms of guiding. So we can take guidance from that particular statement as well. And what the main risk was with particulate steroid embolizing into a vasculature and clumping up the red cells, ending up causing spinal cord ischemia. And that's what happened. There were few case reports of catastrophizing events. So faculty released a blanket statement regarding the cervical epidurals, so that they have said that steroids must not be given for any transforaminal procedure in the cervical region. And regarding rest of the procedure, they have kept it quite open, because this statement was after expert consensus. What they have said that it's up to the practitioner, if like they are doing lumbar procedures, whether they want to do the particulate or non-particulate. However, there are no great evidence base suggesting huge advantage of particulate steroid over the non-particulate steroid. So they're not good evidence based on RCTs or randomized to show us. So why don't we stick to the more safer side? The way our trust, when I was in UK, they took it that they took the first statement as the blanket statement, and for all the, whether it is lumbar, whether it is translaminar or whether it's transforaminal, they just went on to non-particulate for every. And although there is no study, but I didn't, in the brief period I was there when this guidelines was instituted, I didn't see much difference in terms of response, but it will be interesting to see like if there's any studies or So in terms of dexamethasone versus methylprednisolone.
So I do have a little different perspective as Usman said. Like, so if you see three steroids there that's being commonly used in the pain practice. One is dexamethasone, that's non-particulate. And then there comes the methylprednisolone, that's particulate, and then the triamcinolone, that's particulate as well. So why, I mean, as Usman mentioned, like it's an arterial issue, they go into the arterial. Now, the problem is that it's the particulate size itself. So Dexa don't have any particulate. So if you inject the vertical artery, or if you just accidentally injecting artery pedal weak, so even if they go like the artery, it's just a dexamethasone. But with the methyl and the triamcinolone, the problem is that that's for the beginner's line. So their particle size is slightly bigger than the RBC size, especially the triamcinolone. Their particle size is really big. So once they are into the arterial supply, they are going to go along into the brain. And once they reach into the capillary, they're going to block it. So in that area, going to go ischemic. But the issue into the practice is, I think so small has a different experience. I do have a different experience. I love to use particulate because they have a little better result as compared to non-particulate. In our practice, during our training, we were using a lot of particulate here. And then we were using a lot of methylprednisolone. And then I moved to kind of different setup, and they were using the triamcinolone. And it's just anecdotal. So I just see like the triamcinolone was good. In this institution, we do have triamcinolone, we're using it. It's very important not to use, I know that the British Pain Society do have a statement there. Don't use the particulate whenever you are doing a procedure on the neck in the lateral direction.
Yeah.
Like when the vertebral artery is
That's
covered.
what
So never particulate. Okay, so you don't really know like when your needle has moved, whenever you have hit there, and any particulate going in, it's straight to the brain. Yeah, into the cervical epidural, if you're sure like if you're in epidural space, it doesn't really matter. Because epidural space, you know, it's relatively avascular. There is no structure there that's directly linked to the brain. So we generally use the particulate there into the cervical epidural space. Down in the lumbar, thoracolumbar junction, a really critical area. We have to be really careful there. We're not hitting any RT and DS and everything, just to make sure you're not.
Yeah, anything above L3, like you have to be very. But bringing on to this point, the guidelines from British Pain Society, they highlighted this aspect that there were about 3 case series. It's very small number, it's very less quality of evidence as such, but the 3 catastrophizing events happened just with lumbar epidurals as well, where they are not sure because the mechanism after the autopsy reports were not intravascular. So what they are postulating that it might be due to the preservatives which are used. So some other mechanisms are in place which we are not aware of. So it's just out and about, and we don't know much. Yeah. So the key thing, what is important, that we also give informed consent to the patient, which is very rare in this part of the world here, that give the patient informed consent that these are the things which may happen.
Well, I'm still waiting for the participants to ask questions, but I'm having a really good time, like, asking all the questions I ever wanted to ask. So regarding the volume that you use for this transforaminal, because when you're doing the interlaminar, you put in a lot of volume there. But for the transforaminal, you're having a smaller volume. So what do you, Dr. Usman, put in for your transforaminals, and what volume, and why do you stick to that particular volume?
I think volume requirement reduces quite a lot when you're seeing a good spread. If you put like contrast volumes have to be very less, like just 0.5 mils is sufficient. And when you see the good spread, 1.5 to 2 mils is more than enough. As long as the spread, it's the spread pattern, is the flow pattern which is important, that as long as you're hitting the disc-thecal interface and around the pedicle and the medial spread, then 2 to 3 mils will be more than enough to cause.
And if you put in a lot more volume over there, would that cause kind of like an additional compression there, because the pathology there, it may not run off, or it may run off more towards the outside along the sheath? So
it can also have masking the effects of what you're wanting to see as well. That if it spreads further along, if you're doing a diagnostic log and later on you want to do a pulse radio frequency procedure, then you may not know which nerve you're going for. So
I may just add one
yeah,
with a small there, like point-wise. So you just want to go there, like the disc is there hitting the nerve. I'm just explaining a typical case, like for the radicular patch, the radicular vein there. So you have a disc compressing the nerve, you're doing transforaminal there. So that's actually 5, 4, 3. So 3.
Okay.
So your needle is on the target, you're happy with the contrast spread, and you just want to give the medication in that particular area. So you have planned like 80 milligram of triamcinolone, 40. So if, as Dr. Lamar said, volume, so if you're going to give the 4 mils there, it's a very small space.
Yeah.
Your triamcinolone going to spread maybe half out, half in. And if you give a small volume and you're really on the target there, the 40 milligram going to stay in that foramen there. So you are actually really staying in that area medication-wise. So previously, people were using large volume, not in transforaminal. And other point for the transforaminal, not giving the large volume, you have a radicular artery there.
Absolutely.
So you are generating a lot of pressure. You're going to compress the radicular artery and compression of the nerve, blood supply to the nerve root there. People were using large volumes earlier for the epidural and the caudal, but again, like the point they came to know, the medication is going to give in a specific area. That's not even specific, it's being diffused in a larger area, even to the normal form. So if you're really on the target, small volume is going to work really good. But if you're not on the target, okay, it's your choice.
Yeah, it's mainly the ventral spread which is your
So it's the contrast, like, that will give you an indication. It's like how well it's going to cover the pathology. Finally, we have a question. How well do lumbar epidural steroid injections work in general for radicular pain, which causes nerve impingement?
I think doing the lumbar epidural is like throwing water on a fire all over the place. Yes, you can do it. It will improve, but if you can be as much targeted as possible, so precision is the key here. So yes, they have their place if the abnormality is widespread, bilateral, then as a blanket policy, you're doing epidural. But if you know the precise pathology, in my clinical practice, I tend to prefer more towards transforaminal because you're much more targeted and you're dealing with what the pathology is rather than throwing water everywhere on the fire. You don't know whether it will extinguish it or not.
So in my, I just do like a different little, so many other colleagues like Professor Collimation is doing that. So if it is a radicular pain, I'm combining interlaminar epidural with transforaminal. And that make a lot of sense. So if I don't know, like the question is asking the radicular pain scandid to the disc or the spinal stenosis, or so if it is scandid to the disc in young patients, combining two at the same level really gives you the good results. So actually, you are targeting the culprit from both sides. So in one side, it may not be reaching really. It will be obviously once you see the contrast there, it may be reaching. But if you're injecting from the both sides, like for the same disc L3, if you're injecting from here, your medication is going to cover internal part as well. If you're injecting from there, it's going to cover outer part as well. Okay, we know like we have given the contrast, we can see spread is going in as well, but it's just to make sure like we're covering the both parts.
Now that is like, in terms of if it's a disc pathology, so you would be kind of like looking at whether it's an extraforaminal, foraminal, or paracentral or central. So your approach to epidural would change depending on the pathology. And by combining the two together, you're probably covering it from both sides.
Generally, yes. Yeah. So if the patient is just simply with the spinal stenosis, having the both side leg pains, it may be interlaminar epidural.
Yes, it has its place. It has its place when it's widespread.
Absolutely.
I was talking more in terms of when you know it's very precise, just one level. Then from diagnostic point of view as well, and future implications that doing a precise nerve root for future consideration of pulse radiofrequency of that sort.
Before the patient comes in, it's like you have got patients who have got like CKD, they're diabetics, they've got blood thinners on. How do you bring them for the procedure? What do you do? How do you optimize them?
So typically, like in Southeast Asia, a lot of diabetes, every second patient coming in the pain clinic is diabetic. So you can't say, no, I'm not going to give you the steroid. So you're going to close your shop then. So you don't get the customers. So the main thing, like with every other procedure, like how bad is your diabetes? Is it well controlled? If it's well controlled, tell them the risk associated with the steroids. And that risk is pretty variable with patient to patient. Some patients do brilliant, like even with the 120 milligram of penicillin, and some patients really bad with the 40 milligram penicillin. The risk is always there, okay? So your blood sugar may shoot up like for a week, 2 weeks, 3 weeks, for months even. So having an optimal blood sugar control is really, really important. I do see patients coming up with the acute radicular pain, just dying with the pain, doctor sahab, kuch bhi karte hain, but their sugar is sky high, and it's like this for months, 200 plus, 250 plus. So I don't think so that would be wise touching that patients. So just tell them, we're going to give you medications, go home, get the endocrinologist on board, blood sugar optimal control, and then do something. I do have patients in my practice where the sugar control has gone bad after injection. Optimal control before intervention is really important. So that's the one point. CKD wise, yes, obviously you shouldn't be using the contrast there. In those patients, think twice, like whether they're going to get really benefit from the intervention. If they're going to get really benefit, then plan that. And if you can avoid the contrast by all means, that's very good. But if you can't avoid that, make sure they have their, if they're on dialysis, they have been recently dialyzed, their blood volume is optimized there. Explain them the risk associated with it. If the patient is dialysis dependent, then that's not the pain for you. Like, so they have really gone into that area. But generally, the nephrologists do say about like the contrast, and there are residual functions left in the kidney by injecting these nephrotoxic medication. You may be taking those functions away. So that do make a lot of sense. Like if you can avoid it. But if you can't, like as I said, like make sure if they're on dialysis that has been recently done, blood volume is optimal. If the diabetic control is good. At the same time, what you can do, like you can really dilute your contrast there and use it really carefully. Instead of half a mil or 1 mil, go like maybe 0.25 mils, and take means more than normal time while you're placing the needle and making sure like it's in the appropriate place. Not taking the chance like I'm just going to inject contrast again and see where it's going.
Yeah. What is your, like regarding diabetic patients, like I know it depends upon the setup that whether if you're in private practice, then there is expectation that patient wants the relief from one go. In UK, like what we used to do, sometimes used to stagger, like instead of, for example, if a patient has a sacroiliac pain as well as facet and spinal stenosis, so we used to like spread out the injections 1 month apart of each with reduced dose of steroid, whereas I know we combine a lot of procedures, I do as well, when it comes to private patients that they want relief. But in your institutions, can this be implemented, like instead of giving full dose or combining two procedures, you just spread them apart to reduce the chances of we used to do it in Glasgow.
Yeah, absolutely. That make a lot of sense. You can split the dose there. You can split the interventions there.
Great. So we are almost to that time is like running out now. I would like to really thank you all our panelists, Dr. Atiq, Dr. Usman Bashir, Dr. Romana Durrani. We had some issues with the network connections over there. Dr. Zahid Waheed and Dr. Rian Pervez. Thank you all. And we conclude our session of image-guided interventional pain workshop with that. Thank you.
Thank you.
Thank you very much.